Now we're switching to the next talk. We're ready to the translation from the operating theater, and now we'll hear about the patient prepared for demonstration. So the next talk is a patient, 77 years of age, complaining on pain in middle of the abdomen without a clear connection with the meals. In her history, we know that she, for a long time, has chronic pancreatitis attacks or episodes. At the recent examination, we see that her blood test shows were normal. Her biochemistry showed a bit of amylase elevation, and alkaline phosphatase, it also was elevated a bit. Ultrasound. At the beginning of the month, we saw some mass in pancreas, of cystic type mass or structure. It consists of two adjacent strictures with a total size of 14 by 7 by 5 millimeters, with distinct irregular shape, without the effect of dorsal gain and without signs of vascularization. And pancreatic duct in the body and tail was expanded. MRI. Our specialist suspected that those cysts could be considered as IPMN-BD type, and studying MRI and comparing with 2013. Besides, they saw moderate dilation of bile ducts without signs of stones, and separate ample of the common bile in main pancreatic duct into the duodenum. At the moment, the current diagnosis is chronic pancreatitis with a suspicion on cystic neoplasias of pancreas. We plan to do diagnostic use to confirm the diagnosis of chronic pancreatitis. Would like to define its causes if it's possible. We would like also to inspect those focal cystic lesions to choose the further patient management. Thanks a lot. Dmitry, are there any questions about the patients? There are no questions. Thanks a lot. So now we're ready for translation. Please switch us to the operating theater. Michael, we can see you. Yes. Hello, once again. I would like to greet you from the operating theater. I think we should switch to endoscopy view because Alberto is trying to look at this separate ample of common bile in main pancreatic duct. We see is a large or major papilla.
We can cannulate. So she has recurrent pancreatitis, right? And she has dilation of the pancreatic duct in the body tail.
Body and tail, yes,
and then there is some
dilation of the CBD.
Some dilation of the CBD. So we are in the second portion of the duodenum. So we came out.
Михаил Сергеевич, если можно дать команду для...
Could you tell us, so we can see the ultrasound? Could you please switch to ultrasound?
See here is portal vein, splenic vein, and mesenteric vein. So usually what you can see from here, so we are in the duodenal bulb. On the left side of the screen there is the bile duct, and on the mid part of the pancreatic head you can see the PD, the Wirsung. So we can follow the two ducts down up to the papilla. So this is the pancreatic duct. You can see the Santorini duct. So the Santorini is this one. So very nice image. So we are going towards the neck of the pancreas. So here you can see there are two cystic lesions, or probably one, that is communicating and is very close by. So
Михаил Сергеевич, буквально секундочку, пожалуйста, мы сейчас видим.
Just a couple of words. You just please switch us to ultrasound. Now we see ultrasound. And we're waiting for your comments on ultrasound.
On the screen.
So I see two, or probably one cystic lesion communicating very close to the main pancreatic duct. So this is the Wirsung and this is the Wirsung. So it's probably communicating with the main pancreatic duct. So this is probably a side branch IPMN, which is 13. Let's see the larger of here. So it's 14 by 5 millimeters. So it's you see the duct, the pancreatic duct that goes here from down, that passed and goes inside the cyst. So these are communicating, and so these are most likely IPMN. Also in terms of morphologically, they look very, very similar to. They look typical of a side branch IPMN.
Alex, where is located this?
Алекс, а где располагается это поражение? Где располагается это?
Head of the pancreas.
Neck.
Okay. Is the same location like in MRI pictures?
The MRI picture showed something in the tail.
Yeah.
So I think sometimes what we heard a lot about subjective that EOS is operator dependent, but I think a lot of things are operator dependent. MRI really, if it's not done by somebody who does MRI all the time, you get a lot of bad readings, and sometimes, for example, it happens that they send you patients for lesion that they don't exist. So you spend, I think it's the longest EOS I perform. It takes an hour to exclude because you have an exam that tells you that there is something, but then you don't find anything. So this is the papilla area. She's breathing. So let's put a little bit of water. Okay.
Михаил Сергеевич, что сейчас происходит? Что Альберто делает?
Michael, what's going on? What Alberto is doing? He handed some piece to endoscope, presses some buttons. I'm sorry for that. We did something there. Since we are doing scanning at the level of major papilla to improve the quality of the picture and to avoid some acoustic noise because of the air, Alberto filled in duodenum with water That's one of the tips and tricks.
It's to eliminate some air from the duodenum. So you can see here, so this is the common bile duct. This is the pancreatic duct at the level of the papilla, where measure 3 millimeters, so it's normal. And also so we can follow the bile duct towards the ileum.
Well, let's measure it because there is some dilation.
She has cholecystectomy, right?
Yes.
So
maybe one more because it's.
For cholecystectomy,
Yes.
is a normal. She's 7.5 millimeter with cholecystectomy, and 77, I think, is normal.
Up to 8 millimeter, yes.
You know, usually small, but with age it can also increase of size. And after cholecystectomy, it can. There's a lot of time that they send me patients to with the MRI or CT dilation of the duct with normal liver function test with normal cholestatic pattern where basically you don't find anything. So we just go. So you can see that we can follow the duct. This I call the kissing sign, where the two ducts usually meet from the head to the body. But in this case, you cannot see because there's this cystic lesion that is typical for IPMM. Let's look if we have other lesion in the other pancreatic region. So the way to find the pancreas, there are two ways. One is to go back, find the aorta. So when you find the aorta and you see the celiac and the SMA, you push, and at this point you have the splenic vessels and you have the pancreatic body. And what you do, you follow. So if you want to go from the pancreatic body to the tail, you move your hand clockwise, and so you torque a little bit clockwise, and you bring the right hand with the scope a little bit back, so you can explore all the pancreatic tail. So soon we should see the spleen. So this is the spleen. And so if you move on the opposite direction, so you move anti-clockwise, you come back towards the pancreatic body, pancreatic neck. So, and here you can see the lesions. Here.
Alberto, what can you say about pancreatic parenchyma?
The pancreatic parenchyma looks very normal. So she has no chronic pancreatitis. So one, in people with the recurrent acute pancreatitis, one thing that you find very frequently is chronic pancreatitis, actually. And a cause of recurrent pancreatitis, it might be, you know, a cystic lesion, so like mucinous cystic lesion, like this, that maybe they release some mucus in the ductal system that gets, you know, occluded. So if she has a recurrent pancreatitis, she needs a sphincterotomy.
What do you think about the cause of the abdominal pain in this case?
You know, this is abdominal pain is always a pain. It's painful because you know you assume that the patient has the pain because you find these things. But I think you know, because what Alex was saying, that ERCP has a complication. I think before doing any therapeutic maneuver, you really have to be sure that the symptoms are really related to the pancreas. Because I think ERCP should really be done if she has basically proven recurrent pancreatitis, and at that point she needs a sphincterotomy. And you know, IPMN symptomatic are usually have a little bit more aggressive behavior than asymptomatic patients. Nobody knows why, but a patient with IPMN who present with symptoms are usually worse than patients without symptoms. So one criteria also to do surgery is the presence of symptom or not. In this case, clearly there is no criteria to send the patient to surgery because the lesion is small. So this can be, and she's 77. So I would actually, in theory, if you follow the guidelines, you should follow this lesion once a year. But I think in a 77 years old lady, the probability that she will die from transformation of the cyst is extremely low, and you just create a lot of anxiety and a lot of cost for basically to not obtain anything.
And one more questions and comments. When we, as I clearly understand, there is a pancreatic duct dilation on an MRI. We don't see some dilation.
No. I don't see any dilation, but you know what? It might be possible also that if she has done the MRI during very close to the. So this is a very nice image of the papilla with the two ducts. So the origin of the duct is the same. It's not really. So they are not separated. And I think might be it was dilated because there was an occlusion. And this was the cause of the pancreatitis, and then it resolved. So, sometimes you don't have to say that the test that has done before is wrong. It might be something changed, For example, what we have seen yesterday, we had the patient with a lesion, cystic lesion, and the CT was done 2 months ago, and now yesterday he had a collection. So it happened also the opposite. The patient who are sent to you after acute pancreatitis with collection, then you do a US 2 months later, and you don't find the collection anymore because it has resolved. So I think it's not that the other examination are wrong.
And we have heard information during the course about some markers, for example, mucin, CA, and
for IPMN, I think my way of approaching cyst has changed over time, because I think if you have a good MRI and also with the picture we obtain, I think we can be pretty confident that these are IPMN. And if there would not be IPMN, you would not do anything different than follow them up. So I think I'm actually puncturing the cyst less and less and less. The one thing is very important is to, when you have one uniloculated cyst, is to differentiate if it's a mucinous or if it's a serocystoscarcinoma, because I think what you have to avoid is to send patient to surgery for serocystoscarcinoma. So in that case, usually I puncture, I send for CA amylase, and in serocystoscarcinoma, the CA is very, very low. Usually it's close to 0. So it becomes almost diagnostic for seroadenoma. And now there's also some evidence from to use the confocal the cell vitrio. So you have a confocal probe that you can insert through a 19-gauge needle and gives you a picture that is really nice, and it's typical of serocyst adenoma. But for this type of cyst, this small, I don't think you need to puncture, because I think you already know what they are almost, and even though maybe this can be an IPMN or a serocyst, but what you're going to do is the same. You're going to follow them up. So I would not puncture and put the patient at a risk for a complication where when the puncture does not change what you're going to do. So I think you have to keep in mind that always do maneuvers that have some degree of risk, only if they really change the management of the patient.
Does the age of the patient depends on the follow-up strategy or operating strategy? The patient
assist like this, you would not operate in anybody.
Anybody.
Even if they are 35 years old. Also because, you know, it's in the neck of the pancreas, you know, it's still, I think, clearly then with a young person you become more aggressive with the follow-up because you don't want to miss the cyst transformation. But I would really not recommend surgery unless this, like a cyst like this starts changing. So there's a German school where they treat IPMN as it would be colonic polyps, and they do a lot of surgery. This is in Heidelberg, but I don't think, you know, the pancreatic surgery is much more. You know, also even in a high volume centers, you have a lot of complications because it's the nature of the surgery. So I would actually be very conservative and try to touch only the patient who really needs. So the age is very important to also take into consideration what you're going to do and also how you're going to follow this patient. So she's 77. This cyst is probably not going to change. And at a certain point we have to die, everybody has to die, no? So if she died at 90 years old because of heart or pancreas, or it's the same. So I think at a certain point it's also good not to create anxiety to people. You know, there are people who come with a 5mm cyst that never's gonna do anything, but the fact that they know that they have this cyst creates a lot of anxiety and a lot of you know, medication tests that are basically useless.
Михаил Сергеевич, замечательная демонстрация и
That's a great demonstration, very nice picture of those cysts. And that's a very interesting discussion as well, but should move forward. That's why I would like to thank you for this demonstration. It was great and clear, and I hope we will continue this discussion during the roundtable.
a brilliant case and for your explaining of this case and this cyst. Thank you very much.
Thank you.